Dementia tends to be more of a chronic disorder. So this is a patient who basically has prominent memory disturbances. And not only do they have memory disturbances, but they have other cognitive disturbances as well, even in the absence of the delirium. And there's numerous reasons why patients have dementia. Some of these include neurodegenerative diseases like you find in Alzheimer's, you find in PICs. Maybe it's because of strokes like in vascular dementia. Maybe intracranial processes like patients who have HIV. Maybe it's because of traumatic brain injury. Maybe it's radiation induced. Maybe it's some kind of tumor. Also seizures, metabolic disorders like Wilson's disease, endocrinopathies like hypothyroidism, maybe nutritional deficiencies, and that's what you find in maybe the patients who have substance abuse. They have thiamine deficiency. If you have pernicious anemia, the B12 deficiency, and of course toxins, meaning alcohols and/or medications. So there's numerous reasons why patients get dementia. Overall, about 5% of the population over the age of 65 has dementia, and about 20 to 25% of the population over the age of 80-85 has dementia. The older you are, the most likely that you will have dementia. Some of the dementias are genetic. For example, Alzheimer's disease, Huntington's disease tends to be genetic. Now, the key symptoms of patients who have dementia is the increasing disorientation. Remember, the time, the place, and the person. You typically find that pattern. Disorientation first to time, then to place, then to person. You might find a lot of anxiety. You might find the mood symptoms like depression. You might find emotional lability, personal disturbances, problem in abstract thinking. You could also see psychotic symptoms like hallucinations and/or delusions. As far as the associated findings, that will vary on whether you do neuroimaging studies or neuropsychological tests. And both of them will probably be abnormal depending on which one of these tests you do. The course of the dementia will vary as to what type of dementia, but it's usually considered a slowly deteriorating course. Now, when you do a physical exam, you might find various things. You probably will find some central nervous system motor pathology depending on the dementia. You could find medical problems, and you could even find some substance-specific syndromes. Again, these are all going to be based on the specific dementia. And later on, as I go through this chapter, I will be talking about each of these specific dementias that you need to know about. As far as the diagnostic tests, most of these patients will get at the EEGs. They're going to get neuroimaging. They're going to get neuropsych testing. You probably will do the mini mental status exam and, of course, basic lab exams to rule out the reversible causes. You should remember that 10% of dementias are reversible. And these are the ones that you need to figure out first. So you want to make sure that you check the CBC, check the chemistry panel, check thyroid, check RPR, check folic acid, check all these things in order to determine whether or not these patients have a reversible cause. And if they don't have anything that's reversible and all the blood tests come back negative, then what you're probably looking at is a type of dementia called dementia of the Alzheimer's type. Now let's look at the most common reversible dementias. And remember that 10% of dementias are reversible. And this is a mnemonic. D is for drugs, E is for endocrine, M is for metabolic, E is for emotional, N is for nutritional, T is for tumor trauma, I is for infections, and A is for atherosclerosis, and that spells out dementia. So that's one easy way of memorizing all of the reversible causes of dementia. Now, the treatment of these dementias, of course, is to make sure you treat the underlying condition, make sure you provide support for the family, make sure you provide support for the patient, reassure the family, reassure the patient, and if the patients become agitated, or they have hallucinations, or they become delusional, then of course treat them with antipsychotic medications. And the most common differentials for dementias will be the delirium versus a normal age-related cognitive decline. It's very normal for people to forget things as we get older. However, it's not normal for us to forget basic things like your children's phone numbers, your phone numbers, and things like that, which you tend to not forget. But patients with dementia tend to do that. Now, there are various types of dementias. dementias of the Alzheimer's type, vascular, Pick's disease, Creutzfeldt-Jakob, Huntington's, Parkinson's, HIV-related dementia, and pseudodementia, and I will slowly go over all of these in the next few slides. Let's first talk about dementia of the Alzheimer's type. This, of course, is the most common of all the dementias. So this is probably occurring in about 50 to 60% of the patients who have dementia. When you look at nursing home beds, you will find that 50% or more of those beds are occupied by patients who have dementia of the Alzheimer's type. Let's look at the risk factors for patients who have dementia of the Alzheimer's type. Female is a risk factor. Family history is a risk factor. Any kind of head trauma is a risk factor. And of course, Down syndrome. And the reason that Down's is a risk factor, it's because of the chromosome 21. Patients who have Downs have problems with chromosome 21. Patients with Alzheimer's have problems with chromosome 21. The difference is that the patients with Down syndrome get Alzheimer's disease later on in their life. Later on for Down patients is the 30s, in the 40s, whereas in the regular patients, Alzheimer's doesn't occur until 60s, 70s, etc. Now, what you typically find in patients who have dementia of the Alzheimer's type, as far as neuroanatomical findings, is that you're going to find cortical atrophy, flattened sulci, and enlarged ventricles. So there is a global atrophy of the whole brain. It's not an atrophy in a specific part as you would find in Pick's disease. So this feature is what differentiates Pick's from Alzheimer's. Alzheimer's, the atrophy is all over the brain, whereas in Pick's, the atrophy is in the frontal and or the temporal lobes. Histopathologically, you're going to find senile plaques, granulovascular degeneration, neurofibrillary tangles, and of course, patients with Alzheimer's, we know, have problems with chromosome 21. And what's unique about chromosome 21 is that's where you find the gene for the beta amyloid protein. So these senile plaques are nothing more than deposits of amyloid. Patients with Alzheimer's also have problems with acetylcholine and norepinephrine, and these tend to be in decreased amounts. Specifically, acetylcholine is important because it's linked to memory. So because you have low levels of acetylcholine, your memory deficits are going to appear. When we think of the deterioration in Alzheimer's patients, it's usually been called linear or progressive. So this is basically a very slow deterioration. And the average age is usually about 8 years from onset to death of the disorder. So when you have end-stage Alzheimer's disease, these individuals are nothing more than small children. They're bedridden. They have no sphincter control. They cannot walk. They cannot care for themselves. And basically the family has to do everything for them. They don't know where they are. They don't know what day it is. And of course, they do not recognize family and they do not recognize friends. When you do a physical exam on these Alzheimer's patients, you tend not to find focal deficits or neurological signs and symptoms. And this is what differentiates Alzheimer's from vascular dementia. Because patients who have vascular dementia have ischemic changes all over the brain, you would expect them to have focal deficits or neurological signs. It is normal for patients who have vascular dementia to have right-sided weakness, to have pseudobulbar palsy, to have dysphasias, to have dysarthrias. That is not the case in patients who have Alzheimer's disease. The physical exam is generally benign when you compare it to a patient who has the vascular dementia. Because these patients have low levels of acetylcholine, the treatment of choice for these patients will be long-acting cholinesterase inhibitors, such as you find in Tacrin, donepezil, ribostigmine, and galantamine. And these are the drugs that are given in order to improve the acetylcholine, in order to basically slow down the deterioration, slow down the cognitive decline for these patients. There is a new drug that has been available on the market for at least 1.5 years, if not more. And this is a drug called memantine. What's important about memantine is that it also helps patients who have Alzheimer's disease, except it doesn't work on acetylcholine. Memantine only works on glutamate. So therefore, it affects both glutamate when you use memantine, and when you add one of these long-acting cholinesterase inhibitors to the treatment, you're going to find that patients tend to do better. So ideally, When you have the treatment of either moderate to severe Alzheimer's, the treatment of choice will be memantine and the use of the anticholinesterase inhibitors. Risperidone is also used, or any other atypical antipsychotic can be used. Why? Because many of these patients become delusional. They do have hallucinations. They believe that people are breaking into their house. They believe that someone is trying to kill them. They think that someone is doing horrible things to them. They do hear voices. They do see things. They do become agitated. They do become aggressive. So in those situations, the antipsychotics are the ones that would be indicated. Vascular dementia is the second most common cause of dementia. This occurs in about 15 to 30% of the patients. As far as the risk factors, men tend to have more vascular than women. It tends to occur at an advanced age, yet it is younger. These patients are younger than the patients who have Alzheimer's disease. And these patients tend to have medical conditions such as hypertension, diabetes, CVAs, etc. It will be affecting the small and medium-sized vessels. And because hypertension is one of the leading causes, you will find problems associated with the hypertension. You'll find the elevated blood pressure. You will find the ophthalmological changes. You will find the cardiac enlargement. You will find the carotid bruits. And because these patients have ischemic changes in their brain, when you do a physical exam, what else would you probably find? You will probably find areas of focal deficits or neurological deficits. When you do neuroimaging on these patients, you will definitely see the hyperintensities and the atrophy suggestive of old infarcts. The deterioration in vascular dementia tends to be stepwise or patchy. So when you compare the deterioration seen in an Alzheimer patient versus a vascular patient, the vascular dementia patients tend to occur faster as far as deterioration. So because the symptoms are occurring faster, then what you probably find is that their family is more aware when you compare it to the Alzheimer family. Because these patients have these focal deficits, you will probably find gait disturbances. You will probably find abnormal reflex. And the way we treat patients who have vascular dementia is, of course, treat the underlying condition. Treat the hypertension, treat the strokes, treat anything that is causing it. Always try to teach patients about smoking cessation, trying to correct their cholesterol, and of course there's various techniques that can be used, such as endarterectomy, anticoagulant therapy, or even thrombolytic agents. But luckily, no psychiatrist would ever do any of these things. So these are things that I'm sure you'll go over in detail when you look at the neurology presentation. Now you have a comparison of Alzheimer's versus vascular dementia. So when we look at who gets it, you find that Alzheimer patients are more likely to be women, whereas vascular patients are more likely to be men. Alzheimer patients are probably older, vascular patients are probably younger. One of the causes of Alzheimer's is chromosome 21, among others. For vascular dementia, one of the most common causes is hypertension. The deterioration in Alzheimer's is linear or progressive, whereas in vascular it's stepwise or patchy. You tend to find no focal deficits in Alzheimer's, and the treatment is basically supportive, whereas in vascular you will find the focal deficits, you will find the gait disturbances, and you basically treat the underlying condition. Now let's review the other types of dementia as well. Pick's disease is another type of dementia. However, neuroanatomically, you're going to find atrophy only in the frontal and in the temporal lobe. So these are patients that are going to have Pick bodies in the affected areas of the brain. They do not know what causes Pick's disease, but they do know that it can be genetic, and you see it a lot in men who have a history of this disorder. Clinically, it's very difficult to distinguish from Alzheimer's disease, but what you could see is features of the Kluver-Bucy syndrome. So what you may find in patients who have Pick disease is not only do they have the cognitive deterioration, which is classic of Alzheimer's, but you could see some hyperphagia, you could see some hypersexuality, and of course you could see some passivity. Creutzfeldt is a very rare disease which is caused by a prion. A prion, of course, is a protein that does not have any RNA or DNA material. What's important about Creutzfeldt is that it is the most rapidly progressive of all the dementias. From the time you diagnose Creutzfeldt to your death, what we're looking at is probably a few months. So it is very, very fatal, and it's very quick for you to die from this disorder. So what you're going to find is visual disturbances. You could also find gait disturbances. You're also going to find chorioathetosis as well as myoclonus. Huntington's is a very rare disease, and it usually involves the loss of GABAergic neurons. So Huntington's is characterized by a triad, which is chorioathetosis, psychoses, and dementia. It tends to be with a problem found in the short arm of chromosome number 4. So you're going to have atrophy of the caudate nucleus. And of course, you're going to have a lot of ventricular enlargement. You see more of this in men, and they tend to be relatively young men, and of course, they will probably have a family history. So it's very common to find these patients developing personality disorders. It's very common for these patients to have severe mood symptoms, to have behavioral disturbances, and to be psychotic. And because these things are happening and they're aware of it, it's very common also for these patients to be extremely suicidal. Parkinson's disease is a disorder where you basically have a loss of dopaminergic neurons in the substantia nigra. So basically the average age of onset for Parkinson's disease is between the ages of 50 and 65. So what you have is patients complaining of the pill-rolling tremor, the mask-like face, the shuffling gait, the tremors, the rigidity, so you have cogwheel rigidity, and these are the things that are common. The two most common psychiatric disorders associated with Parkinson's will be depression and dementia. So usually by the time of their death, these patients will either have one or the other, or probably both. What you have in patients with Parkinson's disease is a destruction of the dopaminergic neurons in the substantia nigra. And this is what causes all of the other complications. For example, the numerous reasons why this can occur could be toxins, infections, or even a normal aging process. When you treat Parkinson's disease, remember that dopamine does not cross the blood-brain barrier. So you have to give them substances that will be converted into something else. So you're going to use the dopamine precursors, dopamine agonists, anticholinergic medications, amantadine, as well as selegiline. HIV-related dementia is also a common type of dementia where you will see a patient who probably appears to be depressed. So one of the first things that happens is that you've got patients going to the doctor and complaining of apathy, dysphoric mood, and social withdrawal. So what happens? You get misdiagnosed as having major depression. You get treated with antidepressants, and basically you don't get better because what you have is the beginning of the HIV dementia. So dementia and delirium are probably the two most common psychiatric manifestations of the HIV dementia. So how do we know when someone has HIV dementia? They're probably younger, and they will probably give you risk factors for HIV, whether it be sexual promiscuity, whether it be sharing needles, but something will be present in that case to give you a clue that this is someone who probably has HIV and now as a result has the dementia. When you do the physical exam on these patients, you'll probably find numerous things. For example, gait disturbances, problems with reflexes, and of course some oculomotor deficits. Normal pressure hydrocephalus is another dementia where the patients typically have enlarged ventricles. But when you check the cerebral spinal fluid pressure, you find that the pressure is normal. And that's why it is called normal pressure hydrocephalus. This has a triad, which is dementia, gait apraxia, and urinary incontinence. What's important is that the treatment of normal pressure hydrocephalus will be a shunt. By placing a shunt, the patient will be back to normal. Pseudodementia is very important, and what you need to do here is be able to differentiate pseudodementia from dementia. Pseudodementia is a patient who truly does not have dementia, but it looks like they have dementia. So it's probably an older patient who has depression, but it looks like they have dementia. What is important about the patients with pseudodementia is that because it's due to a mood disturbance, these are individuals who can basically date the onset of their symptoms, whereas patients with dementia cannot. These are patients who can have several manifestations of the disorder which are clearly different from the dementia. Let's review a comparison between pseudodementia and dementia. When we think of pseudodementia, it's something that happens quickly, and because it happens quickly, everyone around you is going to be aware. Because it's due to a mood disturbance and it's happening quickly, you know what's happening. You want help, you're not going to lie, you're not going to hide anything, and you're going to emphasize your disabilities. And when you get antidepressants, you get better. Dementia, on the other hand, is a disorder that's happening slowly. And at the onset, early onset, remember, some of these patients could actually be aware that they're starting to forget. And because they're starting to forget, they don't want anybody to know what's happening. So they're going to lie. They're going to deny everything. And if you ask them a question that they don't know the answer to, what are they going to do? They're going to confabulate. They're going to make up a story. So as far as treatment, if you were to give antidepressants to a patient with dementia, they're not going to get better. But if you give antidepressants to a patient who has pseudodementia, you would definitely expect them to get better. Now let's differentiate delirium versus dementia. We know that deliriums occur quickly, dementias occur slowly. We know that deliriums last days to weeks. We know that dementias last months to years. We know that delirium also has a fluctuating course, whereas dementia has more of a chronic, progressive course. We also know that deliriums have recent memory problems. Dementia has recent memory problems. However, dementia also has remote memory problems as the dementia progresses. We also know that patients who have delirium will have a disruption in their sleep-wake cycle. For any of you who have ever been on call, when is it that the patients with delirium come alive? They come alive in the middle of the night, they're agitated, they're screaming, they're out of control. So during the day, when everyone else is awake, they're sleeping. But at night is when they're awake and active. Whereas patients who have dementia, that is not the case. They basically have a normal sleep-wake cycle. Patients with delirium and patients with dementia have problems with disorientation. However, the patients with delirium, their disorientation fluctuates. There's no specific pattern between one thing and the other, whereas in dementia, there is a pattern. You become disoriented to time, then to place, then, of course, to person. Both delirium and dementia can have hallucinations. However, in dementia, you also experience something called sundowning. And sundowning is as it starts to get dark, when everything starts to fade out, patients become more confused, they become more agitated, they become more out of control. And that typically happens between the hours of 3, 4, 5, 6, depending, of course, what the season is. And the main treatment of delirium is to treat the underlying condition. If it was because of a medication, stop the medication. Whereas in dementia, it's more supportive treatment because there really is no treatment for most of the dementias.